Okay, last one in this unit on regularity of rhythms, the atrial fibrillation lesson. Atrial fib is a very commonly encountered rhythm out there in the world. Many people have it. Lots and lots of old people have it, and they live with it just fine as long as the rate stays okay. Another time we're going to emphasize that. A rhythm that is not normal is one thing, but it's definitely a bad thing if it does not produce a rate that can maintain a blood pressure. So atrial fib in the 70s, 80s, 90s, people live with that all the time. Atrial fib 130, 140, 150 heart rate, people don't live with that for very long. Look at the difference here. The baseline in the top strip is showing you what is really a coarse atrial fib. You can definitely see the fibrillatory waves. And then look over at the diagram, the schematic showing you multiple atrial foci are firing at 300 to 500 times a minute. There's a lot of atrial activity going on up there. Fortunately, the AV node is on duty and doing its job, and it's not letting all of those through. If the AV node let all of those little atrial foci through, then atrial fibrillation would try to cause ventricular fibrillation, and that's a terribly bad thing. So the AV node is protective. Remember, it has two big functions for us right now. One is that it allows an impulse to pause so the atrial kick can stretch the ventricles. And the second is that it prevents atrial chaos from becoming ventricular chaos. In atrial fib, there's really not much atrial contraction. The atria have chaotic electrical activity, but there's no real coordinated mechanical activity, so you're losing that atrial kick. The ventricles are not getting stretched, and that's going to impact your stroke volume. You think back to the Frank Starling mechanism and the Starling's law curve and all that. If you lose that atrial kick, you don't stretch that rubber band, the left ventricle doesn't get stretched before it pumps, it doesn't pump as hard. So atrial fib causes a reduction in stroke volume, which will probably translate to reduction in cardiac output, reduction in blood pressure. And so atrial fib's not a good thing. I don't want to have atrial fib. But if I have atrial fib and I can control the rate, then I can live with atrial fib. So there it is. Now in the bottom, it is a much faster rate, as you can tell. And if you assume it's a 6-second strip, you've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17. That's running at 160 to 170. And that's not a sustainable heart rate. That's not going to make a good blood pressure for very long. So the bottom strip is atrial fib with RVR, rapid ventricular response. The one on top is not quite that fast, atrial fib. Hey, here's atrial fib with RVR, talking about that. And so it is the rate that's the problem. I want that patient's rate controlled. I would like them out of atrial fib, but I'll settle for controlling the rate while they stay in atrial fib. Notice the regularity on these two strips. Yes, it's irregular, but is there any pattern to it? Is it regularly irregular? No, atrial fib is irregular with no pattern. It is irregularly irregular. You can also have it with a slow ventricular response. We've seen this in some hypothermia patients. In this case, you could almost make a case in that top strip, in that V1 strip, that those are P waves, that there's a lot of P waves that are not being conducted. And I would listen to that argument and that explanation. But atrial fib can run fast or can run slow. I think down that V2 strip, you just don't see any coordinated, obvious P waves at all. Coarse atrial fib, they say that when patients first encounter atrial fib, that the fibrillatory waves are very coarse and very obvious, and then over time those waves get smaller and smaller. You may be encountering a person who just went into atrial fib. They've never had it before, don't even know what it is, and you may see this kind of thing. I would also point out that there's a lot of artifact out in the field world, and we make fun of this sort of situation by calling this a normal Broadway rhythm, in that there's enough bumps and potholes and and things on main streets in our world that it looks like this anyway. But the differentiation is that this is irregularly irregular with no definable P waves. Here's fine atrial fib. I'll go back and compare it to coarse. Go back to compare it to fine. And this is what you see most often. And you could make that be muscle tremor. You could make that be a bad electrode contact, poor skin prep. There's lots of things that can give you that junky baseline, that artifact on the baseline. But if you've ruled out all those and the rhythm is irregularly irregular and your patient's older, you're pretty safe bet that it's atrial fib. Atrial fib is kind of a diagnosis of exclusion. You've looked at everything else, you can't find anything else that might be causing it. Yeah, it's probably atrial fib. Atrial fib is very, very common. Any problems with it? Well, yeah. Other than if it's in a normal rate, when it's in a normal rate, clots can actually form in the heart, in the atria, in the chamber, not in the muscle, in the chamber, because the blood flow coming out of the atria is so disrupted, it's so disorganized, it's really barely dumping from gravity, and there's no contraction to help it, and clots will actually form there, and then the clots will be ejected into the ventricles pump them north through the carotids into the brain. And so this is a great way to have a stroke, is to have clots forming in your atria. So atrial fib patients will tend to be on medications to keep clots from forming in order to reduce their stroke risk. And this will be a theme that we talk about throughout the entire course, not just the ECG course, but the entire paramedic course, that there are patients that take medications that help them prevent something bad, but when they have another something bad like trauma, those medications work against them. For example, a blood thinner that would keep clots from forming would reduce Mrs. Smith's risk for heart attack and stroke, particularly if she has atrial fib. She has a risk of stroke, but what if she falls and breaks her hip? Now that blood thinner is no longer working for her, it's working against her. Kind of a common theme that will come up. So very common that patients have atrial fib, very common that they're on a blood thinner, and so that's a risk. And then, as we said, that decreased ventricular stroke volume, you do lose that atrial kick. And so these folks really can't tolerate heart rates of 130s, 140s, and above that. They just can't maintain their blood pressure with that fast of an atrial fibrillation. We want to control that rate if we can't convert that out of atrial fib. We definitely want to control that rate. So that's pretty much the atrial fib thing for now.